they are unresponsive.
Okay.
Okay. If they're unable to communicate with us, or if there's no one else on scene, you get that random call from some bystander that says, hey, there's this passed out girl over here.
Yeah.
You don't know for sure. So these are some of those secret things that you can miss. Of course, your placental abruption and your ruptures, those are a little bit easier to notice. Your ruptures are going to be a little bit boggy. Your placental abruptions typically have that separation, and this has that severe ripping abdominal pain. Mm-hmm. So they're going to have a little more symptoms.
You said the uterine rupture would be boggy, so like when you palpate.
Is this the one, or is it, I'm thinking the other one?
So uterine rupture have the stiffness as well, the abdominal, what's the word, like tightness.
Okay.
A tight abdomen. Or if it's not progressed to that where they have this whole abdomen full of, it might feel foggy. But typically they'll complain of pain without bleeding.
Mm-hmm.
Without bleeding.
Because the wound's all
on the inside of the abdomen.
Okay.
So handling,
but the placental abruption is going to have
severe pain and bleeding.
Okay.
Those are the ones when you guys are doing like PTLS. When you're doing your trauma, your trauma calls, those are the ones that will typically happen with a trauma. That automatic rupture or separation and the falling and the ripping. So, you think about your car accidents or falling down a set of stairs, something traumatic caused that separation to happen. So they'd have the severe pain and the bleeding. Handling preterm labor and premature birth. Regular contractions, they occur most frequently than usual, can be a sign of preterm labor. Monitoring these contractions is essential for early intervention. As we just discussed, you guys don't really have a way to do that. I mean, you could tell if they are, if mom can feel them, you might be able to put your hand on the top of the uterus and be able to feel the contractions. Of course, as imminent labor happens, they're going to come more frequent and closer together. Low back pain can be another sign, and changes in their vaginal discharge. They talk about the mucus plug, they talk about breaking of water. So if they have some changes, the bloody show, different things that they may have as far as discharge changes. Immediate interventions for preterm labor is comfort measures, managing the preterm, emotional support, and pain relief. Probably the worst part about preterm labor, depending on where they are in their cycle. If they are early on in their gestational phase, there's not a whole lot that anyone's going to really be able to do. So supporting them, giving them some kind of understanding, getting them somewhere kind of appropriate to kind of help them through that, because that's going to be the hard part, especially if this was something that had been planned a while, they were already excited about it. It's be a little bit harder sometimes on them. As they get progress and they're further along their gestation, they've already invested in this pregnancy for so long. So you're going to have even more issues as far as supporting them. And then on top of it, you may have more blood going on. They may end up having tissue expelled that's actually more developed. So you've got a lot more traumatic mental trauma that may be happening in that case. So again, trying to get them somewhere where most appropriate. A facility that has a labor and delivery, at least you have staff from labor and delivery that can kind of help them through those processes. They have social workers, where if you just brought them here, they don't really have that. You may not, because it may not justify a interfacility transfer, but at least if you took them somewhere to start with, they're going to get some support that they probably needed.
Well, she needs an intervention because become a life threat situation.
Right.
Go ahead and come back here, or any other hospital, because might not deliver babies, but can, you know, give you some blood products and
Okay,
help
that
stabilize.
would make sense.
Yeah, and then you think about the after,
Yes.
you know, if they are having a miscarriage at that time, if there is anything that may have to be manually removed, doing a DIC, anything like that. Care transport of premature infants, warmth. Warmth is a big thing, monitoring vital signs and proper positioning. Warmth is super, super, super crucial. For us on the aircraft, we carry a full foil bunting. I was gonna try to bring one. It literally is a piece of foil that's wrapped like this, and it's basically a blanket. It's like you shove them in it, you wrap them up, and it keeps them warm. It's
So is it similar to our warming blanket or emergency blanket?
like your adult ones? Yes, they look very similar to that. I feel like they're a little bit thinner. I haven't opened it up.
Really?
Yeah, like it literally feels like foil wrapping.
Yes.
Like that's all.
Without the tearing consistency.
So do you
It
wrap
feels
a
like the-
blanket around it, like, or
I
like gift
personally
wrap?
would. I haven't. I honestly have not even
Metallic gift
opened
wrap?
any of them up.
You know how that
We
goes?
just got them last year when we started putting them on our aircraft. No, wasn't it last year?
We've had foil baby buntings for.
Well, 9 didn't get
Yeah.
until like when I started.
So it's like a little wrap for your baby, like a little receiving
It's a
blanket.
little burrito.
Yep. So what do you guys have on the truck for?
What's your
Strange.
OB look like?
Mhm,
The heater in the back?
Okay.
And we
And
don't
just
even carry the
blankets and-
emergency blankets, do we?
You have a head or a hat.
We do in the OB kits, I believe.
Yeah.
Okay.
Yeah.
Got that, and they got a little blanket.
Yeah.
So those may be things
Your
that
OB
you
kit
may
wrapping.
consider getting, because again, you could put them in it, then wrap your blanket around it, and that's going to.
Our
Really
hands
control
are
the-
tied. I mean, they're not gonna allow us to do, you know,
Wow.
they're not gonna order those. Yeah.
Okay.
Because that, I mean, we had, I don't wanna say we had free reign, but we had constraints, you know, we had to be approved by Bozeman, we had to be approved by Tim. But, you know, we could order, us as supervisors get together and say, we think this is a really good idea and suggest it and send it up the chain and it'd be on the truck the next couple of weeks, but it's not
Gotcha.
that way anymore.
Gotcha. Do you guys online have anything you want to share? Any input, any questions, anything?
I ignored them. Sorry.
Your APGAR scores, of course, if you are imminent and you guys are having deliveries babies, your APGAR score is absolutely crucial. Do you have something in the truck that maybe gives you a reminder of what it is, how to do it? Because again, it's one of those things, if you're not practicing, it's not something, you're not in a pediatric based facility.
Yeah.
Mhm. But does it just tell you, hey, get an APGAR score? I mean, which honestly, I probably don't necessarily have one either. It would be me getting online and
We
looking
have
at
it in
pictures.
our protocols.
Okay, that's good to know.
I see it so much. I couldn't tell you between PALS and teaching over at college. I
Mhm.
see it enough that I don't know if it's in the actual protocol
Mhm.
listed or.
So I'm looking at these, about half of the OB kits for EMS that I'm finding on Google, about half of them have the foil bunting. in there, So
Okay.
you'll not have them.
Okay. Those don't expire. I've been wanting to open one up and see what's in it.
I don't think they do.
I was thinking, I wonder, I think they have, some of them that we've had have a printout of the APGAR scoring as well.
Okay.
I wanna say,
I'll have to look. I get my hand
I
on
might be
extra,
lying.
so a couple extras, I may bring some. You got your picture you need?
36, is that what you said?
Chris, did you get your picture?
Yes.
Then you got my radio and I'll do that.
Managing postpartum hemorrhage. So risk factors, uterine atony, so the muscles are now not as strong as they should be. You've lost muscle tone. retained placental tissue, and delivery trauma. You know, this is kind of what we just talked about with if they are starting to have a spontaneous loss of their pregnancy. You know, you've got that placental tissue still in there, or if they've already actually had a birth and they had a traumatic detachment of the placenta, they could still have some tissue. So if you have a mom that ends up you're getting called on that already went home and now they're having some infection symptoms, they're looking a little bit septic, you know, the high heart rate, the low blood pressure, they're running fever, this could be something that they've got going on. They may have some of the placenta be retained. You know, we live in an area where home birth is becoming fairly common, you know, not just here, but actually a common thing amongst. So this is something that you could potentially see. Traumatic deliveries, you know, of course, you could still have those hemorrhaging if you're doing a home birth again. If they are not doing proper postpartum care, you know, rubbing the fundus, rubbing the uterine, make sure that those muscles are contracting to stop the bleeding post-birth. You know, you could end up having some excess bleeding.
That's where we need our cats to make the biscuits.
Oh.
Yes. Pregnancy cats.
That would be like the best therapy ever. Postpartum nursing would go, it would be legit.
Postpartum feline therapy.
Yes. So interestingly enough, about a month ago, somebody randomly texted me and said, "Do you know a good midwife?"
Yeah.
No,
I wouldn't.
No.
I think that's a horrible idea. I think if you want to go do it at the hotel in Mountain Home or at Batesville somewhere right there close,
But this
by
was in
all means.
Horseshoe.
No, absolutely not. No way.
I don't know if the patient was actually in Horseshoe, but the person who was asking lived in Horseshoe.
My goodness.
So
No.
That sounds like horseshoe.
No.
I've transported an accidental home birth from Harrison.
Oh.
And we took the baby because we got there first. The baby was okay. They're good.
So again, assessment and initial management, like that is one of our top skills. Our main priority, get in there, assess the situation and decide what our plan is. Is this something that is a load and go, or we can stay and play a minute? You know, so you're going to assess bleeding assessment, immediate management techniques, fluid resuscitation, your transport prep, your transport prep. You know, again, where are you guys at? Are you in the middle of rural nowhere and it's going to take you an hour and a half or so to get somewhere, and you've got somebody that is maybe in labor, but they're not necessarily intimate? You know, is this something that you consider calling an aircraft for?
Yeah.
And then knowing what kind of aircraft to call. Honestly, in the rotor world, I don't really want to take the chance of taking somebody in labor. But if you call me on the airplane, because I have more ability to move, I have more access, that is something that it could be a little bit more doable. So knowing where your facilities are and
I
what
think
you're,
that the extended time related to the airplane.
That is
between
true.
the
So
airport,
that's-
then drive to you, then get the patient, drive back, fly where we're going.
Mhm.
Now, a helicopter, I'm gonna sit down in your yard, I'm gonna pick you up, put you in, take you somewhere, drop you off on the rooftop, and you're there.
Mhm.
Like, if it appears that it's gonna be imminent pretty soon, that's something that especially if there's a facility between where I'm at and where I'm going, if there's somewhere in between that may not have OB, but they have a doctor, you know, if we have to stop there, we can stop there. But I'm also like, you know, the fact that in the airplane we have more room, so it's just a time, it's
Yep.
a game.
I
of
think
timing.
back to
Yeah.
some
Which
of
any
the,
patient is, if you think about it.
Yeah, for sure.
Yeah.
because I think back to some of the times that, you know, we had 5 deliveries and within a couple of years here.
Yeah.
You know, there were several patients.
COVID babies.
Yeah,
Yes.
we had COVID babies.
Mhm.
But I can remember the one specific of the Mennonite woman that came who was eclamptic and starting to have seizures, but she had not given birth. And then she was so early on that Dr. Gray ended up going with the children's flight. You know, that's one of those. It's kind of like, you know, would it have been the situation? Would it have been easier to do something? You know, she definitely needed to fly.
Yeah.
So
Yes.
Children's come and pick them up.
children's came and picked them up from here. and doc fluid. So something
Without being,
they did not have a physician on the flight that day. I don't remember exactly what happened, but I remember it
why was you
because
thinking children don't accept unless they're born, after they're born?
I don't remember exactly the details, but I remember for sure that Dr. Gray went with him because me and him went back and forth of which one was going to go, and because I had not got my RN yet. I was still an LPN and not an RN. He got to go and I did not. So that was the reasoning behind it, because she was so intimately possible because of the eclampsia and everything that they wanted that extra person.
Wow.
So, but those types of things, just knowing your resources, knowing where things are, what's in the best interest of the patient. Again, is it you guys calling us on scene and we ground pound it with you? Sure. Let's go.
That had to have been a power, like Mennonite or Amish, just being around technology first of all, and then being in that
Yes.
situation, not
Yeah.
understanding, and then being put on a helicopter.
Yes, it was very, very interesting.
Wow.
You'll have to ask Dr. Gray that story because he tells it all the time, and he was late to come to the clinic because it was on a Sunday and he was coming to the clinic Monday morning. Someone had to, Michelle had to go get him, so he was still married to Michelle. She had to go to Little Rock and go pick him
That's a
up.
long time ago.
It's been a long time. So we talked about transport, fluids, fluid resuscitation. That's basically with any of your patients that are going to need fluids. Is this because they're hypo? Have they lost blood? So you guys don't have blood. You can give a little bit of fluid volume. We don't want to completely dilute them out. So be cautious of that. But if they need some fluids, by all means, give them some fluids. Stabilization, transport considerations, patient stability, continuous monitoring, and IV access. So we kind of already talked about whether or not you had the ability to check, fetal heart tones. But what if after you've already birthed a child, do you guys have the ability to now take care of and monitor two patients? Can you monitor mom and baby?
I think you would monitor mom manually. I mean, we have 2 pulse oxes typically on a truck, and so you would just do a manual blood pressure, which I don't think would have a cuff that would fit a newborn, would we?
So that may be some things just to consider, calling.
Yeah, we don't have a neonate or a newborn, we have an infant.
We got a neonate pulse ox.
So you would definitely want to monitor that because that'll give you an idea of your perfusion, and if you're perfusing, you have some type of blood pressure, and it's put it on the left hand first because of the PDA. It helps you to monitor that, and then temperature and pulse ox for sure, and that might be all that you're able to monitor. And then your EKG for just cardiac.
We could put the little couple down.
Yeah.
Yeah, if they're chunky enough for sure.
They will
Yeah.
work on that. We've done it before.
Go to 5.
But at least playing out the scenarios of pre-planning. If you get called on something like that, is that something you say, hey, I want 2102 with me instead of just one of you guys going? You take both trucks.
Yeah.
It's that type of thing. Just knowing your resources, what your limitations are, and where you're going to take them. So.
Well, I'm not even sure if we could transport because we're not going to have anything. Basinger just got through talking about you don't transport unless you're secure, and secure is not with mother anymore. Which I guess when you're in that position, you just got to do what you got to do. But
I know for us in the airplane, we have our P mate, but that's only for so high. Then we have the neo mate. But if we have a child, we're actually okay to do skin to skin, and we secure with us.
Yeah,
So I don't know if that's the same thing on the ground though, because that may be a ground law.
Because even the FAA.
But I would probably say we need to put a second truck, put the medic in one truck, put both medics in one truck, so they got, each one of you can take care of.
Take your
one
other
patient.
monitor with you, secured in.
Take care of one patient, each one of them take care of one patient.
especially if I didn't remember to bring my cat that day, and I got to do some massaging.
Yep.
Oh my goodness.
Or again, just knowing who's on the
Go get
scene.
Lola. You gotta go buy a big Lola.
I don't know if I want Mabel. I don't.
So now you've got your call. Now you gotta worry about what all's gotta be in your paperwork. So you're gonna document your gravida and your para, how many times they've been pregnant, how many they had live pregnancies, have they, just because this is their first pregnancy to come to term does not mean that they had not had some previously. How many live births they had, how many live children they had, were any of these births twins or multiples, those types of things. Any type of prenatal care, like Tasia just said, she got a phone call asking if there was a midwife out there. Do you consider that prenatal care or not? That's kind of one of those, it is, but it's kind of missing some parts that they're going to do within the OB setting. Has there been a rupture of membranes? Have they lost, the mucus plug? Have their water broke? Are their contractions consistent? Are they in active labor? What kind of interventions do we need to do? You end up delivering this baby and they come out pretty blue and,
Pretty blue.
pretty blue.
Was it like an indigo?
Pretty not, that give you the spidey senses of ick blue.
Sky blue.
What do we need to do? Do you guys have
Blue
the
bonnet
ability?
blue.
Do you have the ability to oxygenate this child or get, warmth is our number one thing. We want to keep them warm because we don't need to have them using what little bit of energy they have staying warm when they need to be getting it to get their breathing going, getting, all the things as coming out of their nice little warm, wet home.
Yeah, they go from being an indoor cat to an outdoor cat, and they're gonna need a little transition.
I don't be
You'll be
mad.
mad.
So we talked
That's
about
my favorite comparison.
And that blue something fell on me, you mad.
we just talked about vital signs. Terry had just read her messages. We do not in our kits now. I think she was talking about
The bunting.
the bunting maybe. So
She must have tore one apart then.
okay.
And you have towels and chucks and
Yes.
blankets
I mean,
wrapped up.
What is
Yes.
what is the one thing EMS is really, really good at?
Still in your sheets.
That's not your son. Hey, it's not just sheets. It's not just sheets.
But that is part of it. We adapt.
Everything.
I really
is
thought that's what
overground.
Resources are available at that time.
We adapt and we overcome.
Yeah.
Have you heard the
we
story about
improvise.
Big Mike's then getting in trouble for trying to steal a cardiac monitor?
No.
Yeah,
I love
Little
this
Rock.
story
Listen,
already.
he has sticky fingers. Mike will get his hands on whatever,
If it
including
ain't
your phone.
$10
Don't leave it.
down.
Randy hid and watched when he was carrying it out of the hospital and security stopped him and got the cardiac monitor from him. Is it UAMS? Is that where they were at?
So embarrassed.
Oh, he'll hold up his arms with everything. If it looks like it, well, I can use that.
Oh my god.
Which his service is in a lot better shape than what it was back then.
Well, he also worked with another one, it was real bad, so.
AUT. Yeah.
Yeah. I
So,
was wondering about Wendell. You know what I'm talking about, don't you?
I work for you.
Yeah,
People
we
come
know
and take your IV kits out of your
Yes, I
AR.
know. And when
Yep.
you're doing state
Make sure you
checkoffs,
take
he will
everything.
also cross out the expiration dates and write them on before he hands them back.
Oh my god.
Take all the stuff I want.
Terry Duncan said we can always, Terry Duncan texted and said we can also use their heating pads.
That's very
Oh, yeah.
smart.
Yes.
You also have, do you guys have hot packs?
Yeah.
You can always use some hot packs, wrap them up in some pillowcases, and then wrap them in with your blankets or whatever. Again, EMS, we improvise, we adapt and we overcome. We
Yes.
make things work to be able to get to our patient to where what is in the best interest.
Yes.
We talked about monitoring vitals. That's if you can, maybe this birth went very uneventful, normal birth, normal issues, APGAR looks great, but mom's not doing so hot. You kind of have to decide. Mom's not doing so hot, so you may have to decide what's most important. Do I need to monitor mom's vitals or do I need to take care of baby's vitals?
Yeah.
Crowning, checking for crowning. That's one things that none of us want to do. We walk in there and be like, Okay. Just hold your legs together. I don't want to see it. But you do have to check. You know, you've got to check if they're having contractions, they're close together, you're gonna have to look.
I was like, Chris, look in the rearview mirror and see if you see anything.
Now, drive faster,
Oh my
Taylor.
God.
You're gonna suction the mouth, then the nose. Keep in mind, just think about yourself. If you can't ever remember which one you suction first, do you want to put your snot in your mouth? No, you don't.
No.
Don't do it to the baby. Suction the mouth, then suction the nose.
Or I also think of 1, 2.
Yeah.
One oral cavity, 2 nostrils. So just like you're counting 1, 2.
Oh,
Yep.
Yeah.
okay.
You're gonna clamp and cut the cord. Now, when we're doing this, we're going to keep in mind where baby is in relation to mom. Because if we, what is it, too
You
high
raise
up?
it too high.
Yep, if we put baby up too high above mom, where's all blood that's still going through that umbilical cord? Yep, it's
All
sucking out of
gravity.
baby, going right back into mom.
Yeah.
We don't want that. So make sure you're paying attention to the positioning of your baby when you're getting ready to cut and remove the cord.
Okay.
Placental delivery, after
So
you
do you
deliver
wanna-
baby,
Like at the same level?
yes.
Yes.
Okay.
Same level.
Because the same thing, if they're too loud, they'll get more
Mhm.
and they can have
Okay.
an overload situation.
All right,
Little bitty
Terry,
lungs can't keep too much.
Terry also says you used to always put mother on stretcher opposite end of if delivery is coming.
That makes sense.
So you would look in the rear view.
No, I won't.
I mean, that makes sense because think about it, if you're driving down the road and you put mom's butt towards the door, how are you going to be watching?
Yeah.
You
Well,
can't.
And it also is a safety issue for you if you need to be in a seat versus
Mhm.
sitting at the end of the structure trying to look.
Exactly.
This is actually in a chair,
Mhm.
so.
Which actually, we kind of discussed this in our aircraft the other day because the plane, the way our stretcher system sits up, there is a
No way.
chair kind of at the foot, but there's also a chair at the head, but it doesn't spin. So we were talking about this really in relationship are intubated or having to intubate patients. Our head is at the front of the aircraft, but there's a seat that sits right there that does not turn around. So it's kind of like we would have to figure out how we would position ourselves to be able to intubate. Because I had asked, can we load them feet first so that way now their head is by the back chair and it's the way the plane is, it won't let you do it. So, but that's one of those things of paying attention to positioning.
So do you do tomahawk or what do you?
You can let go.
To be
in the back of the
100%
chair.
honest, I'd be in the back of the chair, and if I didn't think I could do that, they're getting a king.
Okay.
I'm dropping a king.
So do y'all do
not
kings or do you do IGELs?
We do kings on adults. We do iGels on peds until we no longer have kings. So supposedly they're not manufacturing
Yeah.
anymore.
But I think ours got full.
So we did pull ours originally, and then we were given the okay that we could continue to keep them
On
until
adults.
they expire, and then we will go to all iGels. Well, we'll see. So placental delivery, we kind of talked about this a little bit already. If you leave this thing in place, it can cause infection. So we want to make sure that the placenta is delivered intact. Keep in mind, there are families and banks of stem cells that want to keep this. So this needs to go in some kind of container and get delivered with mom and baby. There's also certain religions that also do some rituals with their placentas as well. So they may be asking for it. Yep.
And sometimes if there
Yes,
is a spontaneous abortion miscarriage situation, they'll send that placenta into the lab to see if there's any malformations or anything that they can identify that went wrong. Yeah, that caused the abortion, the fetal death, whatever caused the fetal demise, they might send that out to be looked at under the microscope.
Advancements in technology.
Mhm.
Mm-hmm.
We're going to assess the cord approximately 3 inches. So on this, do you guys have UVCs? Do you have the stuff? Do you have the ability to cannulate a umbilical?
It just used to be a large syringe. I don't remember what size needle.
Okay. I have to think, we actually have a kit that has everything in it.
Yeah,
that
we don't.
So we have actually a UVC catheter and
Mhm.
all the things. If that is something you guys are interested in, Johnny is an NRP instructor, and that's what he does for all the survival flight. He does our NRP stuff and our umbilical cannulation. So if you guys are interested in getting that, you can always reach out to him.
Well, if they ever ask our opinion,
Yeah.
we'll
Or NRP.
suggest it.
Mhm. Yeah. As we've hit on several times, and we will keep harping on it, keep that baby warm. Whatever way you got to, skin to skin, hot packs, multiple blankets, turn the heat up in the truck, whatever. Keep that baby warm. Monitor your vital signs and your APGAR score. Your APGAR score isn't going to just be one set, it's going to actually be two.
One at
Mhm.
1 minute and one at 5 minutes?
Yep. So if
It's
you're
up to-
obviously going to have a longer transport, then obviously you need to be doing
Six.
the multiples.
Also, do not delay resuscitation to get an APGAR. If you're
Facts.
resuscitating, your APGAR is less than 5.
Yep.
So,
Again, what's in the best interest of your patient? Documentation can wait.
Yes.
Numbers can wait. You take care of that patient. ABCs. More gyno emergencies. Anybody need a break? Or are we good to go? Everybody still good?
I'm fine.
Okay.
Do you need one? No? You look so tired.
I don't think there's much any more slides.
No, I'm halfway
And
through.
this is kind of a repeated of the
Yeah,
last.
I feel like a lot of them, but we only got 16 to go, so we're already more than halfway through. Again, assessments, you're gonna see how many times they've been pregnant, how many lives burst. This part here is, we're gonna look at their estimated date of conception. I had to really think hard of what the heck the word was before I had to text her. I'm like, oh, that's what that is.
When
So,
they had
when did they get
sex.
pregnant?
Yeah.
Let me
When
tell
did they
y'all
last have contact?
How old I
Did
am.
you? My mom had a very good Valentine's Day. That's how I know.
Their last menstrual cycle, but their last menstrual cycle may not be a good indicator on anything. So, you have people that are on medications that cause them to be irregular, hormones that cause you to be irregular, stress is a thing.
And you might even have pseudo menstruation
Mm-hmm.
throughout your pregnancy. And you're
Yes.
like, oh, I
Yeah.
didn't know there was a baby in there.
That's why you have those people say, I had no idea I was pregnant.
Yeah.
Yeah.
I just thought I had to go to the bathroom.
Yeah.
Never makes any sense, but it happens. Patient received any prenatal care like we discussed earlier. Are we expecting multiple births? Have they had any issues in previous pregnancies? You know, just like we talked earlier, we knew that there was someone in our community here that had an eclamptic episode. So that'd be something that if she got pregnant again, that would need to be, you know, a consideration had she had another birth and you guys had to transport or something. That, you know, you'd want to know that that was an issue in the previous one.
I wonder if she got shunned.
Surely not. I wouldn't think, oh, no, I know she did. So that was one of the weird things. They had to get approval from the elders. And it was, you have to ask Dr. Gray to tell the whole story. But if I remember right, there was all kinds of other things involved. So, so is there any vaginal bleeding? If so, how much, how long, you know, is this a, whoa, sorry guys, I don't know what I'm doing.
Keep going, that's great.
So you can hit your arrows.
I figured that out now. I tried to do it earlier and it wasn't changing forward, it changes back though. How long is bleeding, history of a miscarriage. So this bleeding, is this bleeding because of a miscarriage? Is this bleeding because, you know,
Placenta previa.
some, traumatic event, anything along those lines. Domestic violence and pregnancy is a thing. So sometimes getting the mom into a safe place where she can answer questions, you know, openly without feeling, you know, eyes on her or ears around her, those kind of things you want to take into consideration.
Well, more so than that, father and daughter Got a lot of
Yep.
incest around here.
Yep, that is one of those things to consider as well. So, knowing your situation and how to maybe mitigate, is law enforcement needed? Are you able to maybe convince family to let you have a minute woman to woman if you end up being, lucky enough to have a female paramedic on at that time? Let's say you guys do get a OB call. Would you rather send one truck who may be all male, or would you rather send your other truck that you actually may have a female on board? Is that something that needs to be considered at the time? A lot of times I just do it because, hey, that's who's in Mammoth, so that truck's going, but, depending on the call, maybe it's better to what's in the best interest of the patient.
There's Purple Road in Stone County, and it's Vest Road. Is it Vest Road in Melbourne?
I'm not sure. I know that CJ was raised in Stone County and we don't go over there.
It's Purple Road.
It's Purple Road now.
Yeah,
Mhm.
yeah.
Oh, Lord.
And I would say it's the Vest.
Could be best.
Mhm. So, like I say, if there's any
Jumbo
reported
Road.
trauma,
Jumbo.
and even reported trauma, is there a history at this house for domestic violence?
That'd be Jumbo.
Just knowing, the type of calls that you've gone on previously, and is that a consideration when you go on an OB call?
That's when you wanna take extra
Yes, sir.
careful time for, your documentation. Cause if it might go to deposition, but you wanna make sure you have everything.
Yep, you put everything in quotes. You never assume anything, but whatever your patient states, everything is quoted. Just make it very clear. You don't want to incriminate yourself, and you don't want to paint your picture with an assumption.
Mhm.
So,
Very objective, subjective, what they say, what you see.
yep. Common emergencies, ectopic pregnancy, ovarian torsion. So ectopic pregnancies, this one, we have a case study at the end, but another one that we had to kind of discuss was, you get a call and all you get is you got a 32-year-old female unresponsive. Okay, you get on scene and your blood pressure is 60/38. Your heart rate's 130, but she's unresponsive. She's not able to tell you anything. She doesn't look super pregnant, or maybe she's on the heavier side, so you can't really tell. Whenever we're pregnant and we have some extra fluff with us, it doesn't really show as much. So when you get on call, is the assumption, hey, maybe she's just drunk, or maybe she's this? Well, maybe she had an ectopic rupture and she's hypovolemic, she's bleeding on the inside. I mean, those are just some considerations that you have to put in your differential diagnosis. Is that a possibility? So if you go on a call thinking that, oh, maybe it's just, a overdose or something along those lines, you would possibly bring them here.
Mhm.
But if then you think outside the box of, oh, this could be something OB, this could be ectopic, that's going to change your transport decision. You're probably going to go somewhere a little bit bigger that has OB. Torsion, those are painful. Of course, the main thing is getting them somewhere where they have surgery, so that way they can get in there, get the blood flow corrected, so maybe they can continue to have reproductive function later on. Same thing, we're talking on OB emergencies, but this is also the same thing with testicular torsion. Men will end up doing the same thing, and it's the same treatment. Get them somewhere surgical where they can repair the blood flow. Assessment, identifications, tough history gathering. Like we just said, you have that 32-year-old female that may be unresponsive and can't give you anything. You may not know she's pregnant. You may not know really anything that was going on. So just knowing that age range, that, those things could be a factor. Your physical examination, knowing and trusting your assessment skills, using, practicing your assessment skills and knowing that that's your first line. You're going to use those, you're going to use your vital signs, and understanding presenting symptoms. Stabilization and management, pain relief techniques, knowing what things you have on board that you can use and what things are not compatible with pregnancy. What
Chris,
are your
was that
black
you
spots?
at an earlier age?
Black box.
I think that's Lance.
He's
Like
way
Lance
too
Hines.
happy.
Yeah.
It looks like Lance Hines.
He's a new grad.
He ain't been in it long enough.
Yeah.
Vital signs of stabilization and supportive care during transport. Knowing your X, A, B, C, D, E. What is X again? You just went P.
Exsanguination.
Exactly. We're checking for bleeding first.
I'm gonna do it exabsity. I'm sorry.
Oh, I love that.
Yeah, exabsity.
Supportive care. Again,
That'd be
thinking
another big word for Granville.
You'll
What-
have him-
what resources
She'll say,
you
"Linda."
have in your facilities and different things. More OB emergencies.
Just a list of them.
Abruptoplacenta, amniotic sac presentation, breech presentation, meconium, placenta previa, prolapse cord, and preeclampsia and eclampsia. Basically knowing them and knowing what your plan is with them. You know, if you have a breech presentation, you know, do you want to spend the time coming here knowing that if you came here, the only thing they can do is deliver. They do not have surgery.
So is that helicopter capable?
Not if they're imminent.
Yeah.
No, not if they're contracting, you know, every 2
Drive.
minutes. and-
What I would probably recommend, and I don't know if they could even do it, you take your doc out of your ER, that puts your doc on diversion. Or you put your ER on diversion because you now have a ER that is non-functioning because you have no doctor. So it's kind of want to figure out, I would be getting on the phone and asking my medical director, what do you want me to do? This is what I got. And this is how long it's going to take me to get to this place versus this place. What do you want me to do? And they may tell you, come here and pick me up, or they may tell you to haul your butt.
They're gonna say haul
They're gonna
ass, I'm
say,
sure.
You got,
I'm
you
sure
got
they
any more
would.
metal left?
Which
You
would
have
that
to-
be a TraumaCon? Like, could you call
Yep.
TraumaCon for
The
that?
trauma con call.
Technically, that would be a
Good trauma.
trauma.
Yeah, that's trauma.
It could be for
And
trauma.
yeah, honestly, I like TraumaCon regardless, because even if it's not a
They'll tell you
trauma,
what the
they are a
dashboard. Yeah.
resource. I will
That's
use
a,
them.
yeah.
Tell you what
I
the
use
button
them for STEMIs. I use them for, because if I fly somewhere that's not my normal region and I'm flying with someone who is new to their own base, I'll use TraumaCon and be like, hey, what's close to me?
Yep.
I've got a stroke. I've got a STEMI. I've got a something. Where can I go?
Give me a phone number.
Mhm.
We're on the road.
Your prolapse cord, your meconium stain, what's, that's a sign of, and what do you want to prepare for? Suctioning is a big thing as soon as that baby's head pops out, because you don't want them to inhale and aspirate on that meconium. You want to get that out of there. So, airway
One.
for those babies is quick.
You mean 1 second, 2 seconds?
No,
No, no.
We're talking
Section
about-
this first.
Oh,
Section
okay.
this second.
Yeah,
Or you
One
could-
whole
or you
first,
could
two
think-
whole second.
You don't want someone sticking your boogers in your mouth. Don't do it to the baby.
So one,
But
one mouth, two
to
nostrils.
take that one step further, we're gonna take the ET tube with the meconium aspirator, suction the meconium, and then take the same ET tube and intubate them.
Okay, well, that was one of my
Do we
questions.
want boogers or poop? I'm just wondering.
That one I've never understood either. Could I not just swap my ET tube?
I mean, you're okay.
I probably would.
Yeah.
Personally, because I don't, because now my
Well,
nurse,
no, because we
nurse
only
side
have
of me-
a 2, a 2.5, a 3, a 3. We don't have 2 of each size of the small ones. So,
Well,
I'm
shoot, in
gonna-
our world, how many times have you tried to intubate and you have a failed airway and you lay your laryngoscope down, it falls on the floor, you just
Oh,
pick
yeah.
it back up and just put it back in.
don't let me die. Don't give me.
No, I'm not
what
talking about
I
animals,
know.
I'm not talking about
Just
kids.
give me what someone, Nelson and Bank. I don't, like, it'll be okay. You can pick it up out of the Applebee's. I don't care. I don't care about any food.
Communication and
Taste
coordination.
that garlic.
So as we've discussed with each one of these emergencies is effective communication, whether that is with the patients in your family or even with your partners in your facility. Communication is what helps everything work together. If you don't have those resources, you reach out and say, hey, help me, then you can do a lot more for your patient.
Maybe
That
I call
EMT
Adrianne,
there
"Adrianne,
is-
help me.
That EMT
We do
there
that
has seen
often.
some things.
The one in the bottom corner, or
I was thinking the one in the middle, but yeah, she kind of looks like she's seen some things.
She's been
too,
here a
so-
minute. This one looks like he just got off of 48, 72 hour shift. She's getting reports, she's like, oh hell, what am I getting
Shit
into?
change, yeah.
So clear communication, compassionate interactions, and alleviating anxiety. Lots of open communication and explaining what you're fixing to do or what the possibilities there are to come will help alleviate some of the anxiety.
So the anxiety, is that also what we were talking about earlier in the cardiac, like we're assuming
Hypoxia first.
hypoxia? Okay.
Because again, with your pregnancy, what has pushed way up here?
And then they have a decreased,
Yep, cardiac flow.
decreased space in their
Mhm.
lung. Oh, I can't remember what the word is, but a decreased, volume inside of their lungs.
So coordination with your hospital staff, your emergency team, early activation. We talk about that for STEMIs. We talk about it for strokes. These are no different. You know, early activation. So that way you let that ER know. Because guess what? Most of them ER nurses are going to be terrified too. And the first thing they're doing is calling it labor and delivery. Oh, hell no, I'm not delivering this baby down here. Or I'm not doing this.
Get the
So
order
the
out of the
early
closet.
activation so they can get the OB and the labor and delivery nurses down where they belong.
Knock the dust off.
Exactly.
how does this thing turn on?
Oh,
the battery's dead. Plug it in. That's
Docu-
meds.
Documentation and report best practicing. Clear communications, importance of accurate documentation, and your legal implications. As we all know, people are so happy these days, and especially when children are involved, and especially when they are super, super young. So cover your butts, write your times, document a clear picture of everything that happened. Here's your case study. 32-year-old pregnant female, 34 weeks gestation, gravid of 3, part of 2, present with severe abdominal pain and vaginal bleeding. She reports sudden onset of constant tearing pain in her lower abdomen that started 30 minutes ago while she was resting. She denies any trauma, but states she has some mild cramping throughout the day. She appears anxious and pale.
Does she know she's pregnant?
She said yes, because she's got 34 weeks gestation, and she answered your gravid and para.
Again, I don't know how to read, apparently. This is like the third time this class.
That's
I was using a
okay.
picture for clues. It was like, well, yeah, she's gonna be.
Yes. That doesn't mean anything. We had a guy earlier. So what do we think right now? It could be some differential diagnoses. What are we thinking already with just this?
Placental abruption.
Because this is just what you're getting from dispatch. This is just what dispatch told you.
So that's a lot more than what we're gonna get from
I
our
know.
dispatch.
That is true. You had
We don't know
somebody
what's
that
going
decided
on.
that they were done being a medic, but they were bored, so they went to go work dispatch.
Yeah.
That's why. So you go in and you go into your assessment. Your general impression: she's pale, she's diaphoretic, she's visibly uncomfortable. Her airway is patent, so I mean, at least it is open and she's breathing. Tachypneic, she's got lung sounds that are clear. Her circulation, she's got a weak rapid pulse. Her blood pressure is low at 88/56. She is cool and
I
clammy.
ain't gonna waste no time.
Fetal heart movements are reported decreased compared to earlier today. The OP history, she has no known complications during her prior pregnancies and no history of hypertension or preeclampsia.
Hypovolemic shock.
But why?
Pressure and the increased heart rate.
So suspected condition, placental abruption, consider it due to the severe pain, the vaginal bleeding, the hypotension, and the signs of shock. Differential diagnosis, placenta previa, preterm labor, uterine rupture, miscarriage, and traumatic bleeding. You know, these are some things that you suspect the worst, but you know there are always some other things that can happen.
So I've got a stupid question, and probably the ones up there in Zoom, I was like, oh, she shut up. So mother is hypovolemic. Do we assume baby is hypovolemic?
Yep, because mom is, baby is too.
Okay.
Just like if mom is hypoxic,
Baby's
baby's
hypoxic.
hypoxic.
Okay.
So yes, you would. So you would still do fluid resuscitation on mom. And remember, their volume is actually higher during pregnancy than it is during our normal.
Okay.
You know,
This is the 50%.
hmm
Okay.
so we want to make sure that they've got, you know,
Here, between second and third trimester.
so that's why recognizing your signs, knowing your signs of shock, and recognizing you're bleeding early, whether this is a known pregnancy that is further along in gestation or something that is ectopic and nobody, maybe she doesn't even know she's pregnant. You know, maybe she is responsive, but she doesn't know she's pregnant, but she has all the other signs of hypovolemic shock. You know, she's in that age range of, you know, still able to have reproduction. So you don't know. You treat based on what you do know, which is hypovolemic shock. So let's go ahead and treat that.
Okay.
And then err on the side of caution of, is this a pregnancy? So what things do I not want to give? You know, what are some contraindicated meds? What are, you know, knowing those things going into it.
Okay.
So your pre-hospital treatment, you gave oxygen, high flow, nasal non-rebreather, 15 liters, because we always assume anxiety is hypoxia. We're positioning left lateral recumbent. Why?
To reduce that pressure.
Vagal.
The vagal. Yep. We're going to help that cardiac return. The IV access, you're going to treat it just like hypovolemic shock, 2 large bore IVs, and you're going to do some fluids. And
18
support.
gauge or higher?
Yeah, I mean, I'm still probably going
Well,
with
if you have to
20s,
give
but
her
whatever.
blood.
You
I
can
mean, we
give
can't
blood through a 20.
Right, but
I'm still 100% give a 20 gauge and call it a day.
20 is my favorite.
It is mine too. Unless they have some big old rocking ropes, and I'm like,
Yeah.
I just want to see. I haven't used the 16 and it's fixed to expire. Monitor your vital signs, continuous reassessment, your blood pressure, your heart rate. Remember, these are your documentation. Document. EKG monitoring.
I see you putting that in your narrative. Use 16 gauge because it was about to expire.
I probably would, and then take it out before I submit it. Pain management, avoid opioids, you know, unless absolutely necessary, because they may depress the fetal and maternal respiratory drive.
So
You know,
fentanyl.
Yeah.
Is that what you?
I have I think that would be the best. I know in the hospital they can stay off.
I don't even know.
Stay off. Or that was the trend back in the day.
I don't know if I've heard anybody get. I mean, granted, I don't work OB, so I don't know.
So, if I'm in labor, which I won't ever have it, y'all better do something. I don't care. If I'm in labor, my baby needs some narcotics too.
But that's also playing into that. If you do decide to go a certain route, knowing what the adverse reactions could be. So if you do go that, can you manage a respiratory, you know, depression? Yeah, you guys are trained to do that.
Yeah.
You know how to use a BBM, you know how to drop a king, you know how to intubate if you have to. You do what you have to do. You know, treat your patient as necessary and appropriate. Rapid transport, get them to the most appropriate facility in the quickest and safest way possible. Reassessment, continuous monitoring. This is just a repeat. This is just kind of an algorithm of what we just went through. Communicate with the receiving facility of the rapid OB team. This is that early activation. The sooner you let them know, the sooner people be ready and prepared. Your handoff report, you know, you tell them what you saw, you tell them what you did, your other signs, and your transport decision, you know, 10 minutes out from the hospital. If you can give it earlier, I mean, we called report to Memphis 20 minutes out. You know, that gives all the trauma team, all of them time to gather what they need, get ready for us to come, and then we give them a 5-minute update to say, hey, we're 5 minutes out, fixing the land on your rooftop, no changes. Or if there were changes, we could tell them. And conclusion, importance of your knowledge, recognizing your signs, and effective coordination. Again, knowing and training what your protocols are, training, knowing what supplies you have, knowing how to use them, running through scenarios, like we just went through a bunch of them. If you have a home birth, what do you guys gonna possibly plan to do? Do you need to have a second truck?
Don't call
Yeah.
Tasia.
Do you need it?
Activate air.
Activate
That's a
air.
great point, yeah.
Absolutely.
Because again,
That's a really
tell them
great
you need
point.
two.
I swear, no,
Yes.
me, I used to work for Airvac 12 and Airvac 40. We rendezvoused on the scene and picked up the mom and baby. She accidentally birthed at home. So,
And you separate.
And you
mom
can,
baby? Oh, yeah.
because honestly,
Yeah.
if we have to go by ground, you now have two
Two
extra
stations.
clinicians with you in the back of that truck.
Yes.
yeah.
With extra equipment, because we will have our monitor, we'll have our bags, so we'll be able to help if for some reason baby hasn't delivered yet on scene.
Mhm.
We can, and we don't have to meet you at scene. We can rendezvous with you. So if you guys wanted to start your way to the hospital, then you guys pick a spot somewhere in that route and say, we want to meet here.
Look for my lights.
So that way, well, yes and no, because then we still gotta find a landing zone.
You can land right up there, I mean.
But, knowing kind of ahead of time what your game plan may be, if
Yes.
this were to happen, what would I do? So,
I don't remember what patient it was that we had. It was you and me over there at Viola, and we were supposed to land at the school, and we kept just going, or somewhere, and you're like, well, we're gonna go up here to this one, well, we're gonna go up here to
Yeah,
this one.
the other
We're
one,
gonna, like, just get me somewhere.
they kept wanting to go further.
Oh, man.
It was like 3 or 4 different, they
Yeah.
changed her 4 different times. And I think it was airback, wasn't it?
Yeah, those are-
Terry just put in that she stopped several times to pick up other medics. Again, knowing, for instance, if we can't fly, again, knowing that you guys have a second truck here,
Yeah.
hey, meet me outside. I'm grabbing you as we're headed to Baxter.
Yeah.
Whatever, or hey, meet me over here. I need your medic,
See
get in
my
the truck
lights,
with me.
holler on hospital, we'll rendezvous right here, wherever we
Yeah.
want.
Just making a plan ahead of time, so. But any questions, any
do have a
concerns, any
question.
other tips added?
I think y'all already talked about this, I think it's probably while I was gone, but like the step-by-step using that Napoleon aspirator. Cause last time we were checking off trucks, and I was putting stuff away and everything, I'm looking at the Napoleon aspirator, I'm like looking up online and different stuff. How does all that
I
connect?
have a video somewhere, but she can explain, but I have a video that I will send you that I made for all of our clinicians
Okay.
of every piece of equipment that we carry.
Okay,
So
'cause
I
it
will
made
find that and
sense
send it to
in
Tasia.
school when I'm like going through school, and then I get in the back of the truck and I'm like, this does not make sense the
They
way it
don't
did,
work out
like
until you
when,
come together.
Yeah.
exactly.
But so it just, it's the end of the ET tube
Okay.
fits into that adapter,
Mhm.
and then the suction fits onto it. Then it has a port that you close it open, just like a
Okay.
yonker, yeah.
Mhm.
And so
Okay.
that's how you suction with it.
Okay, and so then now do I need my laryngoscope, or is this just as far as the eye can see? Does that make sense?
Yeah. I would
Am I
have my
just suctioning
laryngoscope handy,
Okay,
and you could probably even look while you're suctioning. I don't know, actually, to the.
Yeah.
I don't think
Let
they've
me-
ever said.
So I'll
to
look for
be-
that video and send it to you, and then like I told Tasia, Johnny does NRP
You might
for
as well
our
be a
company, so.
Just he might as well be a doctor.
He does NRP for us, so that may be something that he can come do for you guys, and he would probably be able to explain and go over that as well as the UBC.
You do.
Do you need me to put you down for hours on our, and get you certificates, or are you good?
I just researched, I was due this Slack rotation. So, I mean, I may or may not, honestly,
It does
we do
not
so much
say
education,
specifically.
like
It says,
in-house, that I
That's
have more
simulate
than
before you
enough hours.
suction. You don't want
And
them
now
to-
that we
Yeah.
have started doing our
So suction
advanced
mouth and the nose, with the
certification
tongue
stuff,
after,
so like with my
while
CFR, and I have to have
simultaneously providing
certain
oxygen for the blood on it.
classes to keep that up to
And
date,
then-
those would all go for my,
Okay.
under,
that's
My-
exactly.
my
what
lower
I did too,
certificates,
is
it will cover
Make
those.
Okay.
I don't
Making
think.
a lot of assumptions about what I knew.
Well, thanks, guys, I enjoyed
So
seeing
I
y'all,
guess-
hopefully I can see you again
necessarily,
soon.
but I don't see the recurring